Hi, everyone. This is Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. Welcome to today's Journal Club. As always, I'd like to thank ESGO and IJCS for their support in our Journal Club. Before we begin, I want to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We're recording today's discussions, and the recording will be made publicly available. So participants with cameras turned on may appear in the video recording. We ask that everyone please keep your microphones muted so everyone can hear the presentations. And if you're having any difficulties or questions, please send a message in the chat and our technical support team will assist you. We definitely encourage and we'll have time for questions and answers. And certainly you can submit your questions via the chat function throughout today's session. So really excited about presenting this journal club. This month's lead article is Circulating Tumor DNA in the Diagnosis of Ovarian Cancer, a Systematic Review by Cristina Taliento from University of Ferrara, Department of Medical Sciences, Ferrara, Italy, and Giuseppe Vizzielli from University of Udine, Department of Medicine in Udine, Italy. Really, very pleased to welcome you both. Thank you for submitting your article. Thank you for accepting our invitation and sharing your knowledge as it pertains to this topic. We're really looking forward to this discussion. So very excited. Certainly, again, of course, obviously, we have our first group of fellows from 2026, and they're looking forward to asking their questions. And again, really admirable that they're at the Journal Club from all regions of the world. So for some of them, it's in the middle of the night, and we really, truly appreciate that very much. So we will start with a presentation, and thank you again, Cristina and Giuseppe, for joining us. And I'll turn it over to Cristina for her presentation.
Hello,
Thank you, Pedro.
everyone. Hello, everyone. Thank you very much. And first of all, thank you very much for the kind invitation and for the opportunity to present our systematic review today. Also, I'd like to really say thank you to all the co-authors. I will briefly summarize this systematic review on the diagnostic accuracy of circulating tumor DNA in ovarian cancer. So, as a brief introduction, ctDNA refers to the fraction of cell-free DNA circulating in the blood that originates specifically from tumor cells. It carries tumor-specific molecular features, and since it can be obtained through a blood sample, ctDNA represents a minimally invasive biomarker with potential application in diagnosis, prognosis, and disease monitoring. We decided to perform this systematic review because despite of the growing interest in ctDNA, we noticed a lack of a comprehensive analysis of the literature, specifically addressing its diagnostic role. And for this reason, we decided to systematically collect and analyze all available studies reporting diagnostic accuracy outcome for ctDNA in ovarian cancer. And we performed this systematic review on April 9, 2024, and the screening process was conducted independently by 2 reviewers. And we included only studies analyzing plasma and/or serum samples. We did not include studies where samples like ascites or urine or other fluid were used. And we included only studies comparing 2 groups, a study group including patients with epithelial or non-epithelial ovarian cancer, and the control group composed of healthy individuals or patients with benign conditions. So we excluded studies that did not report diagnostic accuracy metric such as specificity, sensitivity, or IUC. And we also excluded basket studies, including multiple solid tumor studies where ovarian cancer results were not reported as separate results. The review was conducted following the PRISMA guidelines, PRISMA 2020 guidelines, and we assessed the risk of bias using the QUADAS-2 tool, which is specifically designed for diagnostic accuracy studies. And here the results. In total, 172 records were identified through database searching, and after screening, 19 observational studies met our inclusion criteria. Across the included studies, about 74 of research groups adopted PCR-based approach focusing on epigenetic alteration, particularly DNA methylation or promoter regions in selected target genes. These target genes varied a lot across the studies, and as illustrated in the figure on the right, where we try to visually summarize this heterogeneity. Most of the investigated targets were tumor suppressor genes, for which an association with ovarian cancer had been previously reported. And also, this heterogeneity across studies was not limited to target selection. There was also substantial variability in laboratory protocols, sample size, and analytical workflows. And for this reason, no meta-analysis or other attempts to pool the results were performed. And as we expected, we observed wide variability in diagnostic performance with reported sensitivity ranging from 40.6% to 94.7% and specificity from 56% to 100%. Almost all studies are including patients with both early stage and advanced stage in ovarian cancer with the study group. And the results on the diagnostic accuracy was reported for the overall population without differentiating really between early and advanced disease. And one way to assess clinical validity is by evaluating concordance between ctDNA detected in plasma or serum and corresponding tumor tissue. However, this information was available only in a small subset of studies, just 3, and concordance ranged from moderate to strong. And it should be also acknowledged that these studies did not systematically evaluate the impact of biological factors like stage or ovarian cancer histotype, so it remains unclear whether this discordance is caused by analytical or biological factors. Regarding CA125, only 4 studies reported data allowing a direct comparison with ctDNA. Overall, ctDNA show comparable or in some cases superior diagnostic performance, particularly in early stage disease, as reported in one study. So finally, here are our conclusion to this systematic review on the diagnostic role of ctDNA in ovarian cancer. We observed that the majority of the research groups adopted a PCR-based multi-gene approach using epigenetic alteration, specifically methylation of the genes, to differentiate between normal DNA and the DNA derived from the tumor cells. And looking at diagnostic accuracy reported by the single study, we can conclude that ctDNA is a promising biomarker. However, given the high variability across the included studies, pooling the results was not possible. We need for sure more studies in this diagnostic setting, studies assessing also the influence that some biological factors may have, factors like stage, tumor heterogeneity, and also the influence of all the pre-analytical variables that can have an impact on the ability of the assay to detect the low amount of ctDNA as we expected to have in early disease. And thank you very much for your attention, and I look forward to the discussion.
Well, Cristina, thank you so much. That was presented so well, so clear, and really a very important topic. You know, in our country now, most patients are actually coming in and asking for their ctDNA to be drawn, and often there is a discussion as to the fact that we really don't know what to do with those results and also the variations in terms of on one visit it's positive, on one other visit is negative. The patient is doing fine, the
Yeah.
CA-125 is fine. So I think it, certainly provides for a really great opportunity for discussion. So with that, and I see already questions are coming in. Lots of people have joined the journal club. So again, very excited to hear your thoughts on these questions. And first, we're going to go to Dr. Nicole Chris at the University of Western Australia, where it is, I believe, 3 a.m. So thank you, Nicole, for joining, and you'll have the first question.
Thank you. For listeners who may not be familiar with cell-free DNA and circulating tumor DNA, could you explain how each of these are actually obtained and what's their current clinical and research use?
Well, thank you for the question, and thank you for being here. Cell-free DNA refers to all the fragmented DNA that circulates freely in the bloodstream. All cells in the body can potentially contribute to cell-free DNA. Most of them are hematopoietic cells, epithelial cells, and cells from various tissues that have a normal physiological cell turnover. Inflammation and tissue injuries and other conditions can increase cell-free DNA release. While with the term circulating tumor DNA or ctDNA, we are referring specifically to this small fraction, less than 1% of cell-free DNA that originates from cancer cells. And before DNA extraction, there is a pre-analytical phase includes how the sample is collected or handled, stored, and what temperature. Many of these factors may affect cell-free DNA integrity and may influence ctDNA detection, and they can vary a lot across studies. So we then extract DNA from the blood sample, typically plasma, but it can also be serum or other body fluids. And after DNA extraction, we want to differentiate this tumor DNA from all the normal DNA that floats around the blood. Using sequencing or PCR-based approach, we can identify tumor-specific genomic alterations. So you can look at one single feature or multiple features together. For example, single mutations, copy number variants, methylation patterns, or fragmentomics profiles. And once we do that, depending on the ctDNA test that you are using, the assay provides a sort of output. This can be binary, ctDNA detected or not, or quantitative, such as a tumor fraction, which represents the proportion of cell-free DNA that is derived from the cancer. For example, a variant allele fraction of 10% means that 10% of the circulating cell-free DNA carries tumor-derived DNA. This then allows clinical questions because we can ask ourselves, can this tumor fraction be associated with prognosis? Can we correlate ctDNA detection or pardon with how long patients survive? Well, the prognostic role of ctDNA is something well established in the literature, I would say, for solid tumor, but maybe also for ovarian cancer. We have some pool results, studies assessing prognostic role of ctDNA. We performed a meta-analysis in 2024, and we found that patients with detectable levels of ctDNA after treatment had a worse overall survival and progression-free survival compared to patients with undetectable ctDNA. I think it's also important maybe to look at the literature of other solid tumors. For example, for colorectal cancer, there are currently around 10 ongoing randomized trials worldwide testing whether ctDNA-guided adjuvant strategies can actually improve survival outcomes. And also, one common goal here is to pair this accurate diagnostic tool with effective target therapies, because we know that with dead genome alteration, the therapy is likely to be effective. And one most common example, probably in metastatic breast cancer, is the ESR1 mutation, which can predict better response to elacestrant. But you can potentially use ctDNA also for diagnosis. When we started this review, we really wanted to gather all the study reporting sensitivity, specificity, IUC of the assay in diagnostic setting. And what we found was a very diverse picture, different approaches, different target genes, and different results.
Excellent. So thank you so much for outlining the entire scope of how we should view ctDNA and putting it so well and condensing it to this point. I think one of the questions that we always have is, well, we already have CA-125. So how does it compare to that? So with that, I'll turn to Lucia Ribeiro, who is at the European Institute of Oncology in Milano, Italy.
Congratulations first for this paper, Cristina, my dear friend, and Giuseppe.
Yeah.
My question is, the paper suggests that ctDNA might perform better than CA-125 for early detection, but at the same time, there is a lot of heterogeneity. As clinicians, how should we interpret this in real life? Do you think ctDNA should still be used only in research settings for ovarian cancer? Or is there already a scenario where you will feel comfortable ordering in routine practice now?
Thank you, Lucia, for the nice question. And first of all, thank you, Pedro, for all the nice organization for this journal club. This is a not topic. As I told before, now I'm in Milan, and just a few minutes ago we talked about the clinical practice of the use of ctDNA in the early diagnosis of or in the clinical practice. However, at the moment, for the early detection and the differential diagnosis of an SR masses, routine clinical practice relies mostly on body risk prediction models, particularly ultrasound-based model as Annex model, which have show excellent performance even without CA-125. If we add CA-125 and Annex can improve performance in this equation here from advanced ovarian cancer. However, based on the current evidence, I will say that it is too early to feel comfortable ordering ctDNA for early detection in routine clinical practice. There are different sources of false positive and false negative, and a negative ctDNA result does not exclude disease, especially in early stage ovarian cancer where tumor shedding may be low. Given this limitation, routine monitoring of ctDNA and the circulating tumor cells is not recommended, but should be encouraged within the context of next future projects. That said, as reflected also in the NCCN current guidelines, ctDNA may have a role in the selected clinical scenarios, for example, for molecular analysis when tissue biopsy is not available, or when rapid molecular information is needed. But for ovarian cancer, not as a screening or early detection tool at this stage. but this is also an evolving field, so it remains to be seen how the evidence and also why not clinical practice will change over the coming months or years, obviously.
Thank you,
Thank
Giuseppe.
you.
And we do have questions coming in from the chat, and I'll turn to the first question, and this is for you, Cristina or Giuseppe. From Albert Jacob, does the change detected in preoperative ctDNA assessment correlate with subsequent tumor testing? And I would also like to know for what indication ctDNA testing is done for ovarian cancer patients, general screening at your center.
Well, in the current reality, I think that it's very difficult to find some centers that order the ctDNA in diagnosis. I think it's more incorporated for research. And there is also a consensus published in 2024 by experts in ovarian cancer. And in this consensus, the use of ctDNA is very encouraged to be incorporated in new research, in new clinical studies. But I think that at the moment for detection, as far as I know, it's very rare to find a center where they use it. You can use in the ctDNA for example, in the NCCN guidelines, they indicate to use the ctDNA where the tissue is not available to perform some molecular analysis, because it's a non-invasive approach. So we can rely on the blood for this kind of analysis, but the gold standard at the moment remains tissue sample for diagnosis and also for monitoring, I would say, yeah.
Great, thank you, Cristina. And we'll turn to Giuseppe Parisi from the Policlinico Universitario Agostino Gemelli in Rome.
So thank you for the presentation. And of course, congratulations on this excellent work, Giuseppe and Cristina. My question is, given that diagnostic accuracy was primarily assessed using healthy controls rather than patients with conditions that often mimic symptoms of ovarian cancer, as endometriosis or borderline tumors, or as pelvic inflammatory disease, should we reinterpret the reported specificity of ctDNA with caution?
Well, interesting question. Thank you. So I think that from a theoretical point of view, while cell-free DNA could be influenced by other conditions like inflammation that is present in endometriosis, circulating tumor DNA assays are designed to be more specific because they are supposed to detect tumor-specific genomic alterations, which are not expected to be present in benign conditions. However, you are right, because this is a very interesting question, because growing evidence has shown that endometriosis can display also some somatic mutations. You can find somatic mutation in the endometriotic cyst, mutations in cancer-driven genes like KRAS, PIK3CA, and these are also in common with some subtypes of ovarian cancer like clear cell or endometrioid ovarian carcinoma. But I don't think that we have studies assessing how these clinical factors could impact the rate of false positive at the ctDNA testing. In general, how this can affect concordance between tumor and plasma. So I think that validation in clinically relevant control groups will be essential to confirm real-world specificity. But before that, I think it's also very important for future studies on analytical validity to use the standardized samples. Standardized samples are reference materials like cell lines or artificial DNA diluted in a matrix where you know exactly in advance what specific mutations are in there. For example, a reference material with the BRCA1 variant at 3% with 11 variants per assay. But after gathering all these kind of studies, I agree with you that we should really better understand all the sources of false positive in a specific setting of an ovarian mass, where I want to discriminate between benign and malignant lesion.
Excellent. So I'll turn to Giuseppe, because I think, you know, one of the questions that everyone has is like, well, could we see this having a role in early diagnosis? So I'll turn to Anusha Kamath from the All India Institute of Medical Sciences in Nagpur, India. Anusha?
Yeah, hi. I loved your presentation. It was very crisp and clear. My question is that given that for a truly effective early diagnosis of ovarian cancer, the biomarker would need to be detectable before peritoneal carcinomatosis develops. So do you think the current ctDNA assays can realistically achieve this level of ultra early detection?
Okay, thank you. All right, this is an important question, because a truly effective detection in ovarian cancer would ideally happen before peritoneal spread. This could be fantastic when tumor burden is still very low. It's fantastic for surgeon and for patients, obviously. But biologically, that's where the ctDNA faces its biggest challenge, because in those very early phases, the amount of the tumor DNA released into the blood is often extremely small. So at the moment, we don't really have a clear answer as to whether current ctDNA assay can consistently achieve the level of ultra early detection of ovarian cancer. One of the main reasons is that the most available studies include both early and advanced stages. So that means that overall performance is often driven by patients with more advanced tumor where ctDNA levels are higher. Only a few studies reports stage-specific accuracy. This is a bias of many studies in literature. So one example is that the study by Wong et al. In 2017, which shows similar sensitivity in early and advanced stages, but that alone it's not enough to conclude that ctDNA can reliably detect disease before peritoneal carcinomatosis. So I will say that ctDNA is clearly promising, and the technology is improving quickly, but whether it can truly deliver ultra early detection in ovarian cancer is still an open question, and maybe will require well-designed prospective study focusing specifically on early stage disease within a homogeneous population.
Thank you.
Yes. So I'll turn to Cristina, because it's a somewhat related question as well. We'll turn to Beat Sarta from the Riga Maternity Hospital in Riga, Latvia. Beat?
Hey, thank you for your excellent presentation. My question is, in other tumor types, ctDNA can already support diagnosis or preclinical detection, but ovarian cancer appears to shed ctDNA much later and in much smaller quantities. Is there any evidence suggesting that ctDNA could become a pre-cancer mitosis diagnostic tool in ovarian cancer, or does its biology inevitably limit its usefulness to stages with established tumor burden?
Yes, thank you for the question. In early stage, the amount of ctDNA is lower compared to advanced stage. However, its diagnostic roles, specifically in early detection, depends on how our tests are sensitive in detecting ctDNA at low, very tiny concentration. We have been looking for cancer, I would say, for not just recently, but for quite a long time. And the research history of ctDNA has its roots in the 70s. And what's different now, why it is the better time to investigate this biomarker? because we have now current technologies such as NGS, next generation sequencing, we have the cancer genome projects and so on, and all these things together have significantly improved the sensitivity and specificity of ctDNA detection. However, there is still much work to be done to improve assay specificity. And as Professor Vizzielli said, what we found in our review was that in most of the studies, the results on diagnostic accuracy were reported for the overall population, which included both early and advanced stages. So it's difficult to draw conclusions on diagnostic accuracy of ctDNA for early detection only. And there is also another point to remember, I think. There are many pre-analytical variables that have been demonstrated to have an impact on the ability to detect what there is in the specimen. Issues regarding collecting, handling, transport, processing, and storage of the specimen. And we don't know enough, I think, on how these variables may affect diagnostic accuracy of these ctDNA testing.
Excellent. So we'll turn now over to Spain. Naya Seminario, Vallebron Hospital in Spain.
Everyone, and thank you, Cristina and Giuseppe, for your outstanding presentation, and congratulations again for your work. My question is, do you think that research should shift towards validating ctDNA in truly challenging benign comparators? And could this change our perception of its diagnostic value?
Yeah. Thank you for this nice question. Personally, yes, I think that ctDNA has a considerable potential in this field. However, at the moment, discrimination between benign and malignant cell lesion and clinical management decision rely largely on, as we know, ultrasound-based risk prediction models such as the ANNES model, which has undergone extensive external validation. And as we know, they showed excellent diagnostic accuracy with an AUC is around of 0.93, based on the recent meta-analysis. A potential application of ctDNA could be refine our diagnostic ability to identify specific cancer subtypes, for example, by the detection in cell-free DNA of this mutation that are typical of specific subtype, for example, ovarian cancer. This is, I think, my personal opinion.
Excellent. Now we'll turn it over to local, Alvin Matthew here at Houston Methodist Hospital. Alvin.
Thank you all so much for your presentation. My question is, as you stated in your paper, we are so far away from a real-world clinical application of ovarian cancer early detection through ctDNA. If you were designing a prospective trial for early detection with ctDNA, what would be your preferred cohort, method of detection, and promising endpoint?
Well,
easy question from Alvin.
I think it's a very difficult one because it depends, I would say. There is actually a well-established body of literature discussing the challenges of prospective studies designed to evaluate diagnostic biomarkers. Because randomized controlled trials in these settings are very different from the classic drug versus placebo trials. And when you evaluate a diagnostic testing, you're not testing the assay alone, but an entire testing strategies that include how the test results is interpreted, how it influences clinical decision-making, and the downstream management of patients. And these introduce a number of methodological challenges and potential disadvantages compared to therapeutic trials. So because of these complexities, many researchers have explored alternative study design to assess the clinical utility of diagnostic tests and biomarkers, rather than relying exclusively on traditional randomized control trials. And one way, for example, is to build a model comparing 3 strategies. For example, you can select a cohort of patients with annexal mass, and my decision could be option 1, basing my decision on standard diagnostic tool, and option 2, monitor conservatively, again using standard diagnostic tools, or option 3, perform the ctDNA testing, and here, based on the results, if the test is positive, I will operate on the patient, and if then it's negative, I will not. And at the end, I could have maybe 4 options, and for each of them, the patient will be not monitored over time, and one important outcome would be certainly survival, mortality, or also post-operative complications in patients who underwent surgery. So at this point, I think we need to try to really put effort in having more evidence on clinical utility. That is, the clinical utility, it's not only diagnostic accuracy. The clinical utility is the ability to demonstrate an improvement in diagnosis, treatment, prevention with the use of an assay compared with not using the assay. In other words, ctDNA has to be evaluated by looking at the degree to which it leads to actual changes in outcomes that matter to patients. If you just want to assess the accuracy of ctDNA in differentiating between benign and malignant ovarian tumor, that's great, because we still need to explore, to find new assays, to validate the studies already present in the literature, and to report diagnostic accuracy, which is the central role in the whole picture. And I think that the best way here is to assess its prospectively enrolled patient with an annexal lesion, an annexal mass, candidate for surgery, in order to have a reference standard test. The reference standard test would be represented by the definitive histology, and the blood sample would be performed at the time of the enrollment. This is a benefit of having a prospective study, because when we screen the literature in our included studies, many of the study used some biobank samples. So we don't know exactly where they were performed, the exact time prior to surgery, and so on. So this is a great advantage if you want to perform a prospective study. And all the analytical variables in a prospective studies will be performed, will be collected, will be respected in a standardized protocol. And I think that we all agree that ovarian cancer diagnosis at early stages has a better survival compared to a cancer diagnosis at advanced stage. So this is part of the clinical utility. And a test like this would address one of the most important unmet needs in ovarian cancer. However, there are still many questions to address when designing such a trial. For example, does adding this biomarker to commonly used ultrasound-based risk prediction models, such as NX, actually provide a meaningful diagnostic benefit? So future studies, I think, should evaluate the clinical impact of testing on patient care and outcomes, along with potential harms also, such as exposure to unnecessary CT scans or invasive diagnostic procedures. I think that it's very important.
Excellent. So thank you, Cristina. And we'll turn to Turkey, Ankara, Bilkent City Hospital, Ilker.
Thank you. Congratulations, Cristina and Giuseppe, for this interesting article. It was a good experience for us to understand the details in ctDNA. And my question is, considering that many techniques used for ctDNA analysis may require advanced infrastructure and highly trained personnel, potentially creating disparities between technologically advanced hospitals and resource-limited centers. Do you think that introducing ctDNA as a clinical tool could widen the gap in access to the different diagnostic and clinical potential applications of ctDNA in ovarian cancer care? And if so, how could this issue be addressed?
Thank you for your questions. I hear your point, and maybe as for example in surgery, for the robot surgery, despite its in technology, a chest can be a concern. However, our review, particularly in this topic, also showed that many research groups, especially in the context of early detection, have increasingly adopted PCR-based approaches, and these methods are generally less expensive, so technically simpler and more widely available than NGS sequences, which may help improve accessibility and facilitate implementation even in the center with limited resources. That said, to fully address this issue, we need a more comprehensive evaluation of cost and benefits, obviously. At present, there is a lack of robust cost-effectiveness studies at the ctDNA literature, particularly in ovarian cancer. So such analysis will be essential to determine whether ctDNA-based strategy can be implemented sustainably across different settings.
So you spoke, Cristina, about clinical utility, and I'll turn again to now Policlinico Gemelli, Vincenzo Tarantino, who has a question about how do we use it in terms of making treatment decisions.
Yes, thank you. And of course, congratulations from my side as well for this interesting work. So today, the treatment decision in ovarian cancer still rely on histologic confirmation, and even the diagnostic use of ctDNA appears to require integration with the CA-125 and imaging. And with the previous question, we've talked a lot about the use of ctDNA in diagnosis. So given this limitation, do you believe that ctDNA might provide its greatest clinical benefit, not in initial diagnosis, but rather in tracking treatment response, detecting minimal residual disease, and guiding post-treatment follow-up?
Yes, maybe I would say that given the current evidence, there is room for both. Maybe for the diagnostic setting, we should produce more research. However, also for tracking treatment response to monitor the disease, we don't have yet a clear answer if the market could really guide treatment. If we look at the literature for other solid tumors, breast cancer, colorectal cancer, there are more clinical trials that assess survival outcomes comparing ctDNA-guided treatment versus standard treatment. While for ovarian cancer, these kind of studies are strongly needed. And to come back to the consideration about clinical utility, the clinical impact I mentioned before, again, also for monitoring the disease, imagine I may found that ctDNA that could predict relapse 10 months earlier before CT scan. Indeed, this was reported in one study performed by Pereira and colleagues, very important studies, I think, in our field. But the question could be, is there any robust evidence that show that the diagnosis of ovarian cancer relapse some months earlier could truly improve the overall survival? I don't think so. I don't think that we have it. On the other hand, the multicenter randomized study, the DEXTOP3, has found a survival benefit in secondary cytoreductive surgery of localized recurrence combined with chemotherapy when they are operable according to specific criteria. So maybe in this context, diagnosing the early diagnosis of the relapse could have a real benefit, a real clinical utility. So at this point, we really need to assess, I think, the correlation of these biomarkers with the oncological and non-oncological outcomes. It's very important, I think, not to provide the patient just a couple of results, but know how to interpret them and how they can guide the treatment in a certain way.
Excellent. So for the last question from the fellows, I'll turn to Giuseppe. Another important question, one that we haven't really addressed, and that'll go to Leila Abulazzi from Tbilisi State Medical University in Georgia.
First of all, thank you for taking time to discuss your amazing work with us. Although many of these questions, of these points were already covered during the session, could you please summarize what are the limitations that might still reduce the effectiveness of this approach?
Thank you for your nice question. We have several limitations that affect the effectiveness of this approach. Some of these we see before. So this includes false positive results, which may lead to unnecessary, for example, follow-up investigation, treatments, and obviously patient's anxiety, a lack of standardized sampling time points and pre-analytic protocols. And again, variability across analytic approaches. So in addition, as we discussed earlier, false negative results remain the major concern, obviously. Current detection methods may not be sensitive enough to identify very low levels of ctDNA, particularly in early stages of disease where tumor DNA shedding into the circulation is minimal. A key issue in the diagnosis setting is that harm arises when test results do not accurately reflect biological reality. If a test were perfectly sensitive and specific, this will not be a concern. However, where results are imperfect, they may lead to inappropriate clinical decisions. So for this reason, before ctDNA can be fully implemented in a routine clinical practice, several of these aspects still need to be improved. At the same time, this is a rapidly evolving field with many new discoveries emerging. As a result, continuous re-evaluation of the literature will be essential to define the clinical role of the ctDNA over the time.
Excellent. And we'll have one last question from the audience. Thank you for answering that last question. Thank you, Leila, as well. The last question from the audience is, can you imagine a day that ctDNA will become a marker of chemotherapy efficiency as well?
Yes, I don't know, Prof, if you want to reply, but I would say I would say yes, because I'm very optimistic, but we should also be very realistic at this moment. The evidence show that there is the test is very promising, and it's also in a rapidly evolving field. We are learning how to deal with false positive, false negative, and also I think that AI is helping in this discrimination, in improving the diagnostic accuracy. And I would say yes, but of course we have to be also aware that compared to other fields, other solid tumors like colorectal cancer, breast cancer, ovarian cancer has a different history. And also the ctDNA in ovarian cancer has a different history. And we are really try to incorporate these biomarkers, I think, in clinical trials in order to make this dream come true one day. It would be very beneficial for the patient, I think. But also, if I can add another consideration, we should really understand the clinical utility and how the ctDNA can meet the final outcome, and what we have the results from the other trials on ovarian cancer in general, on survival, on drugs, and etc.
Yes.
Well, excellent. Thank you so much, Cristina, Giuseppe. Really, really excellent. What an informative journal club. I feel like you should both give out your email and your phone numbers so that anytime we have a question about the utility of ctDNA or how to integrate it into our treatment plans, we could just quickly reach out to both of you. Really very, very, very impressive. Again, an exciting topic, an exciting field, and we look forward to what's to come as we move forward with further and further information for this. So, Cristina, thank you.
Thank you very much. Thank you very much for the kind invitation.
And Giuseppe, thank you so much as well.
Thank you, Pedro. Thank you, and congratulations for the nice organization of the Journal Club International Journal.
Yes.
Thank you so much, and to all of you, the fellows, for their questions, former fellows who have joined. It's so great to see you joining us, and then seeing you here in the Journal Club. We look forward to hopefully seeing everyone at the ESGO meeting in Copenhagen that's coming up in February. And also want to announce that the February Journal Club will be a discussion, interesting topic, folate receptor alpha as a successful biomarker in the treatment of low-grade serous ovarian cancer patients using preclinical and clinical models. So thank you all so very much. Truly appreciate your support and having you join us for the Journal Club. And again, very informative discussion from Cristina and Giuseppe.
Thank you. Thank you very much.
Thank you.
Bye-bye.
Thank you. Bye-bye. Thank you. Thank you again.